We told you about our main conversation today, and it's about the management of coronavirus. Yesterday, Dr. Tinkrai, he manages all related activities of health, public health in the Ashanti region. He's the director for public health, or the director for health for the Ghana Health Service and for the Ashanti region, and ultimately gave us an indication of how overwhelmed the region is when it came to the management of COVID-19 cases. Coronavirus has really dented and overwhelmed health systems around the world. And so if the numbers incrementally are going up, then the public health officials should be concerned about it. And so we decided to make this a main issue when we're discussing regular topics today. And that's what we're about to discuss. We'll take you to the health service site that is dedicated to coronavirus and the update of the cases. You will in real time get to see what officially the cases are. We do have confirmed cases are up to date, and this is up to date cases of 12,590. Now we have the active cases being the subtraction of the fatalities and then the recoveries out of the number of 12,590 being 8,114 active cases, and out of them we have those that may be critically ill, etc. The main concern, you see the number 397, that is the difference over the last update. So from the last update up to this one that we have 397 additional cases, just 3 shy of 400. That has been the concern for the Ghana Medical Association, the Nurses and Midwifery Council, and then other public health officials. For the Ashanti region to be overwhelmed, we do know that then we're reaching the breaking point. How do we navigate this? Please send us many of your related comments. If you live in the Ashanti region especially, and Kumasi more closely, please tell us what you think about these announcements, not being speculated, but official from the Ghana Health Service officials. And then subsequently, we're going to have all the big people, all the players right here. We're going straight to KCCR, and we'll speak to virologists. And now KCCR is one of the many centers that are testing the cases and giving us the indication whether they're positive or negative. Dr. Michael Lewis is a regular on the show, and he'll take us through a number of things that we need to know. He brings the analysis close to us. Dr. Michael Osu is joining us on stream. Good morning to you, Dr. Osu.
Good morning.
And I'm sure my director will grant me this. We're going to have the site side by side with you. Then you take us through the numbers. You do the analysis for us, what we should be worried about. We have in total up-to-date cases in excess of 12,000. Active cases, 8,100 in excess. But we have 397 being the top-up or the additional from the last time we had an update on the official website. If you look at all these incrementals and the numbers, what does it tell you?
Yeah, good morning to all your listeners and to all your viewers as well. So these numbers is quite worrying and quite disturbing. As I always say, you should not be worried about the cumulative numbers, because the numbers will always increase because the virus will have to run its natural course in every population until about 50 to 60% of people are infected, and you have about 30 to 40% of people who will recover. This is how it behaves when it enters the country. But then the number of new cases you get is what will tell you how well you are doing in terms of management of the virus. And this is what we are beginning to see. We started somewhere from the 12th of March with about 2 new cases. And then we were able to come in with some very good interventions in terms of blocking the borders to prevent importation of cases. We went ahead to ban some social gathering, closing of schools, banning public gatherings, including universities and schools, which was significant. As a matter of fact, if we had not done this, this phase we are will have occurred about a month ago. And because of what we did, we were able to push forward the peak point on the epidemic curve, several months ahead. So we have delayed this period, which is how one of the strategies you use to manage the virus. You cannot prevent infection, but you can manage new cases as they come in. And you have to do it in such a way that you are not overwhelmed by the new cases. So if you look at our data and then a trend of how things are going with regards to Ghana. As a matter of fact, this is not peculiar to Ghana, but it's running through different, in Sub-Saharan Africa, Nigeria, and then South Africa, which have almost similar testing capacity like ours, also experiencing same. So in the month of May, in Ghana, for instance, we started with doing about a daily new case of about 100 new cases, for Ghana, which was quite good. And because of that, we were having very low death rates and high positivity in terms of number of testing we are doing. But then, the new cases were quite good and were quite manageable. And then somewhere in April, we had a lower than that. We had about 50 new cases in April, which was also quite good and manageable. But then in June alone, if you have looked at the Ghana data, we are doing about 280 to 300 new cases on the average. And as you rightly said, as at yesterday, we have about 397. So what we ask ourselves, what is changing? And as I said, it's not peculiar to Ghana. On the 11th of June, the WHO said that it took 98 days for Africa to record its first 100,000 cases. But it has taken 18 days for Africa to record the next 100,000 cases. So in Sub-Saharan Africa, the trend and the pattern of this virus is beginning to change. And the reason is unexplained, but I think that season seems to have a role to play. We started in the hot weather, where the reproductive number of the virus is low, and where the weather is very hot. The virus can remain on surface for up to about 3 days for temperatures more than 25 degrees Celsius. But then, as the temperatures begin to fall, the virus can now stay on surfaces for up to more than 14 days, which means that transmission within the cold season is quite higher than transmission in the high season. So I'm not surprised that the cases are increased. So what this also means is that we are beginning to enter into the exponential phase. So if you have looked at what I told you earlier, Nigeria had about 100 new cases in the month of April. In May, they had about 200 to 250 new cases. In June, they are recording about 400 to 450 new cases. South Africa had about 150 new cases in the month of April. In the month of May, they have about 300 to 400 new cases. And then as we speak now, they are recording close to about 2,800 new cases. That's their current case that they are recording. So the numbers are doubling almost every week, which will mean that if we don't manage things well, it is likely that every week we may see doubling of this number. So if it's only about infection, it wouldn't be a problem. Initially, it started as an infection. If you are infected and you don't experience the symptoms, then you are good to go because people are being infected, but they are not being hospitalized. But then if the infection is correlating with proportional increase in, the number of people who are moving to the health facilities, in other way, it is putting a demand and pressure on the health sector, then it means that the situation is almost changing. So we cannot say that it's largely asymptomatic anymore. But what we are saying that the asymptomatic have perhaps built their base and they are now taking out the vulnerable population one after the other. So it is not surprising to see that in Ashanti region, and I believe other regions will follow suit, you are beginning to see pressure on the health system. Health workers are becoming infected, and many doctors, nurses are becoming exposed, and people are falling out. As a matter of fact, in KCCR, we started by seeing about 1 to 2% of cases out of every 100 tests that we do. But as we speak now, it's getting to about 30 to 40% of positives out of every 100 tests that you run. And most of these are coming from hospitals. It used not to be that. But this tells you that it's not like you have to go to the people anymore, but people are now coming to the hospital by themselves. And as I said, season could be contributing factor, and if we don't change the strategy and begin to relook at how best to deal with this, the coming weeks may double these numbers, and the numbers as they double, it is possible that the deaths may also increase.
Now, Dr. Ernest York, you are president for the Greater Accra chapter of the Ghana Medical Association. Based on the information that is being churned out, especially a concern that has been raised by your colleague who is now in public service, indeed, heads the health service for Ashanti, the exposure of health personnel has a certain risk. I want to ask this question. Is it because you don't have enough of your numbers of your kind in the health sector, or it is because when you are exposed, you're more vulnerable, and so you can be active at the clinical stage of your work?
Thank you, Roland, for having me on your show. Just a slight correction, I'm the chairman of the Greater Accra Division of the GMA, so not the president. We only have one president. Yeah, so back to your question. Yes, by working in an environment where there's a high concentration of affected people or infected people, your chances of contracting the virus is higher. So I think that is a bit simple. And because you are also getting exposed to persons who may have been infected, your chances of, and then are ill, your chances of getting a higher load of virus, or inoculum as we call it, is also high. So the higher the volume or the load of the virus, the more likely you are to, show symptoms. So, you may have been exposed, you may not show symptoms, but if your volume of inoculum or viral load is high, then you are more likely to show symptoms. Remember also that, the chances of getting exposed is also high. It's partly the reason why healthcare are getting exposed. And secondly, because of their risk, we need protection. In terms of personal protection, equipment which has been reported, and I can confirm that is so in the Greater Accra region, that it is woefully inadequate. And we've had to supplement these personal equipment with our own funds, because what is coming from our hospitals, our managers, and the ministry and the government is not enough. I'm aware that the private sector has been involved in individuals, corporate organizations, but over twist, we ask for more because the disease is now on the turn, like the previous speaker was saying. We are yet to see the worst. I think we risk being exposed big time if we don't do things right.
Dr. Usu, if you have to put yourself in the shoes of the health personnel, we're talking additionally nurses. Initially, we were using this word frontline to target those that were directly dealing with positive cases. Now, if you have to use your experience and based on how the positives are being recorded, for which you're saying out of 100 tests now, it's between 30 and 40% being positive, how will you redefine this frontline group conceptually?
Yes, so Roland, the word frontline was quite clear initially from the beginning. And if you have low positivity rates and you know cases that are coming based on your testing capacity, you can easily define that these people are positive and they have you triage them, you know that this is how they are behaving, you test and then you treat, you manage them. But as we speak now, I don't think the word frontline is applicable in the health sector. Every person who is there is a frontline worker, and everybody who is around can be exposed and can be infected because, if the proportion you are seeing on the national average, which is about 6% in routine surveillance, you have 2 times that number occurring. The cases you are seeing now, as in about 12,000 and over cases, there are twice this number in the population, and these are mostly and largely asymptomatics. So these people may come with malaria, and they may come with ordinary fever, and they may come with cholera. Before you realize, they already have the virus. So you may want to consider them as perhaps you are not a frontline worker, so you take them through another route. But then you end up having trouble. And this is what Kofanoti had in their ICU unit, where they were managing less harmful traumatic case. But then before they realized, the person turned out to be positive. A number of them were exposed, and they had to withdraw, and almost half of their staff and now are operating partially. So frontline workers, as where we are now, where we are beginning to climb the epidemic curve, it doesn't look applicable now. Every health worker now is likely is exposed one way or the other, and everybody must get the necessary protection to be able to help themselves. You can't differentiate between what is isolation unit, treatment unit, and then a normal consulting room. So the definition as we speak now, I don't think it holds. It holds well.
Roland, can I add this?
Please add whatever, Dr. York. The floor is yours.
Surely. So I think he just nailed it. And I can confirm for our listeners and our viewers that that is what we are saying. As the cases, inch up, everybody is a line worker. Now, who are you going to take out? Is it the doctor in the consulting room who is getting exposed? Is it the nurse? Is it the cleaner? We forget that, there are support staff that also get exposed in the room. Is it a laboratory worker who is also taking samples? Is it the radiologist who is, imaging somebody who is in the theater? And I can tell you that, I think that initially they probably wanted to refer to those who were specifically at the treatment center. I think they didn't take their time to define. And as you said, time has shown us that that's probably not the case. And I can also let people know that the initial analysis that we've done on persons who have been affected are not those who are found in a treatment center, but they take the maximum level of precautions. The ordinary health worker on the ward in the consulting room, may be exposed, and indeed they are now. They form the majority of those who are exposed compared to those at the treatment center. So I think we should move away from who is frontline at this stage and then look at everybody as being potentially exposed and then deal with it and protect ourselves accordingly.
What is the level of protection in relation to the provision of the PPEs that have been given to your personnel? And it's not only doctors, I'm talking the nurses and the others generally. What reports have reached you, Dr. York?
It's replete with inadequate PPEs. And I think, we don't want to go into what is a PPE. We know what they are now. From the nose mask you are wearing, to the N95, to the goggles, to everything else, to the overalls, to the boots, everything else. So you were using it according to your level of risks. So we don't have adequate numbers, and it scares people. A lot more health workers are getting exposed, and I think we need to change paradigm and let the rhetoric reduce and engage for us to judge and see how best we can go around the situation, because the need is even going higher, yet we are unable to meet. What it means is that especially healthcare workers are going to be exposed more. They will be self-isolating. Unfortunately, some may be sick, lose their lives. The health sector, in terms of the provision, suffers. And then we may see what we are seeing elsewhere. Remember also that we don't have enough critical care doctors. We don't have enough critical care facilities. So where are we going to take care of them? Already we've converted some of our routine theaters and units to take care of COVID. And therefore, routine surgeries that are urgent, that needs to be done, are being delayed or not done at all. Cancer patients are dying immediately because there is no room to operate. So I think as a nation, time has come for us to sit down and stop this media frenzy thing and trying to say, those spread calm, no fear, but on the ground, the situation is different. And I'm afraid as a health worker, for my colleagues and for myself and for my family, I'm having to have some sleepless nights these days.
You are scared for them and for yourself?
Absolutely. Why shouldn't I? I am. Because one, you see, we don't have enough places of isolation in the first place. So you suspect a case, you need to isolate and make sure that you do the test and wear the appropriate things to protect yourself while we are waiting for the results. One, the place to isolate you don't have, so it makes it with the general patient. Two, the personal protective equipment you need to wear to protect yourself you don't have. You take a lab sample and it takes over a week, 2 weeks. I have had colleagues who got exposed and up to 18 days. We didn't have results, and I asked them to come back to work because we're short of staff. So this is the reality on the ground. And so it makes me uncomfortable, and so are my colleagues. And these things must be addressed urgently. Then it doesn't look to me, honestly, that dialogue is being had yet. And I think we are more focusing on painting a picture of everything being rosy, but it is not. Ghana stands the chance of losing everything, all the gains we've made so far, if direction is not changed with respect to COVID management in this country.
Dr. Usu, if Dr. Yours cautions that we need to change the direction, and this also has been supported by a number of experts we've spoken to just over the last 24 hours ago exactly. We're talking about the weather. You also have mentioned it, and the season, and how that we had Dr. Esiembedu from the University of Cape Coast, Dr. Kofi Amega, as well as Professor Marewa, all from that university, postulating that the weather has now hit us hard, and perhaps we should have planned further for it. The question then is, if you look at what transpired in China, the rest of Europe and America, how close are we, based on the numbers we're getting incrementally daily over the last week or two, to get overwhelmed, based on experts' observation?
Yes, Roland, I think that it's important that we really look at the strategy. And like my colleague Dr. Yok mentioned, if you look at the 66 deaths, 9 of these deaths are in people who don't have any underlying condition. This is what makes it scary. The news that is always in comorbid, people with comorbid conditions, the story is not exactly the same. So as young people who are even managing, handling, testing these viruses, you cannot predict how it will behave when you are infected. So it is more difficult. And there's what we call a force of epidemic. As if you have 10 people surrounding you who are all infected, you can put on all the masks you want to put on. The force of epidemic will catch up on you. And this is what is happening. As more people are becoming infected, your risk of exposure increases. So how do we deal with this? I mean, there are strategies to deal with this. They have the mitigation strategy and then the suppression strategy. When we started as a country, we applied the suppression strategy, where you order restrictions, you close borders, you close social gathering, you make people sit home so that you can reduce movement, which is one of the major risk factors for infections. And then give some breathing space for the health sector. I mean, let people plan well, let people inject resources, expand your treatment centers, expand isolation centers, buy PPE, buy laboratory logistics, do all you can do. And then after that, you open up or ease restrictions, whilst you you monitor the cases as they go by. With the way the cases are surging, and with all the contributory factor, and with the possible prediction that these cases are likely to double in the coming weeks, and the deaths are likely to increase, the mitigation measures are in place, wearing of nose masks, which is mandatory and all that. This is fairly good. But then if everybody wears nose masks, you can cut the virus growth by just about 50%. That one will not be enough to reduce pressure at the health facility. If you want to succeed in crashing the epidemic curve, then you will have to go by what China and others did earlier. You will have to impose or order another form of restriction, which will restrict movement, so that as people move, they just stay home. And once they stay home, it gives you some breathing space to manage the few people that come to your health facility, so that at least the health workers will also have a breathing space, because as more of them are becoming infected and are getting out of the facility, it will come to a point where they will empty the place. But then as people are being infected and moving, 2 or 3 times of their numbers are still moving and also infecting. I mean, I know people who are positive, who are supposed to undergo self-isolation, but they decide that they have to go to work because They have to work for their employers. But then if a restriction is ordered and everybody knows that we have to stay home, they will be forced to stay home. And when they stay home, you can have some time, some breathing space to re-inject resources in your health sector, to expand your treatment centers again, to buy all the logistics, to plan properly, and then you can deal with the cases again. So it's not out of place to restrict movement.
Dr. Usu, what are you saying? You are saying we should reimpose lockdown?
How will you reduce pressure at the healthcare facilities? What is the option? One is to expand the isolation units, expand the treatment unit. But do you have time to do this? We can do that. But the virus is running ahead of us. So if you have a virus running ahead of you and is moving at a very faster rate, you need a breathing space and a time to do that. And this is why I earlier said that a form of a localized lockdown is appropriate now. We know where the cases are coming from. If we know that...
Oh. Dr. Uzu, are you on stream? Dr. York, are you there?
Yes, I'm here. I can hear you.
Do you support this localized lockdown, he says?
Well, I think I don't have a yes or no answer, but certainly be one of the considerations to have. I don't think that on the national level, the government will be prepared to do that, considering the socio-political implications of that, and also economic implications. So yes, localized lockdown may be one of the options, to consider. However, I think even as we consider those other options, what about the prescriptions that we've accepted that we should be doing? We say wearing of nose masks, social distancing. Just drive around, the cities and towns. Nobody's observing it. Just a few people, go to the market. It's a few days as if there's no COVID. Go to residential areas. And so the vim and the enthusiasm which we are preaching, we seem to be relaxing as the virus, the proportion increase. And this is a time rather to intensify. I remember seeing policemen, security people along the streets enforcing. Have you seen them again? They are all gone. So yesterday, the Greater Accra issued a statement, and what we were calling for is intensification of and enforcement of these preventive measures, whilst we even think about other interventions as you suggested as localized lockdown. Let's engage the traditional rulers, the chiefs, the queen mothers, the Wolomas, the church leaders, the imams, because they have some social gravitas and leverage that can help, reach out to the ordinary person, so that this enforcement can happen for us to curtail the disease. Otherwise, we are going nowhere. We have very prominent people coming out to say they've infected, and this is what we encourage, to reduce stigma, so that people can voluntarily, offer themselves. And stigmatizing for them, for instance, it's one of the important things that is affecting community tracing, I'm told. People, you give them a call and they say, "Oh, I'm not Mr. W or Mr. Y." They put their phones off, so you can't identify the index case, you can't do contact trace, enhanced contact trace. There are faceted approaches that we must adopt. Certainly, localized lockdown may be an option, but certainly there will be considerations of socio-political and economic costs. But overall, something must change. Otherwise, we are heading in the wrong direction.
Dr. Usu, this drug, Dexamethasone, yeah, Dexamethasone, right?
Yes.
That's the name.
Yes.
It seemed to have overtaken the media airwaves. JoyNews also includes over the last 24 hours. What really is that the miracle drug? It's always been in the stores, apparently.
Yes, I'm sure Dr. York, being a clinician, will come tell us more about this. But then, as the days go by, many people do research. They come up with their findings. They share this with the media space. But then, one of the things we have to note is that the drugs, the various drugs that we keep hearing about, they differ. The way they behave, the way populations and hosts behave to the drug differ from continent to continent. Even within the continent, particular people, based on their own immunological systems and the way they respond to infections, may behave differently. So something may work in the UK, but then if you bring it to Ghana in Africa, it may give you a different picture. And this is why the African CDC has always said that in this COVID era, the drugs that you use will have to be used under a certain condition as a form of a monitoring trial for every drug. And then you generate clinical information to inform decisions as quickly as possible. It's not a wholesale. And in Ghana, we have national treatment guidelines for COVID. We also have other protocols that we are following. So I think as this comes to the media space, the Ghana Health Service, the Ministry of Health will need to reconsider. But then it's not for the public to go and buy it and begin to use it in their homes, but to leave it for the health practitioners to weigh the options to see whether it is possible that this could work within our population. And if it works well, I think that is good. We've heard that you can cut down deaths by 1/3 among those who have severe disease and people who need ventilation support, which is good news. But as to whether populations in Africa will be able to respond to these drugs if they have severe disease is another thing that I think the clinicians on the ground will have to give us more information on this.
Dr. York, Dexamethasone. Dexamethasone. I'm told that it's the new Jesus drug.
No, I mean, it is good news to have a confirmation. I call it a confirmation because I have been involved in managing COVID patients, and I can tell you for a fact that I can, at least for Kolebu Teaching Hospital, we've been using, it comes under a broad category of medications called steroids. And we've been using steroids for moderate to severe cases, those needing RTUK. And what we found that it restricts or improves the the cytokine storm, that leads to some of these bad outcomes. So we know that it works somehow, but this has come to confirm that indeed it may be useful, and therefore we should continue what you're doing, and what you are doing is right. You need that confirmation in scientific circles. But remember what Dr. also said, it is not for you to go and fetch. We did that to hydroxychloroquine and chloroquine. It became short in the market. People started popping it left, right, center. It has side effects. It may be toxic if you not use the right way. Steroids can cause all sorts of problems. It can even paradoxically, remember, reduce your immunity and even increase your risk of getting COVID infection in the first place. So it has to be used under supervised condition by a trained healthcare practitioner under the right, conditions. It can lead to diabetes, it can lead to hypertension. Again, as I said, it can suppress your immunity and a whole lot. So yes, it has come as good news and we are happy. What has to be done is also to probably set up our own protocol to see whether it works to the same extent as it is found somewhere, and so that we can continue to use it safely for the benefit of our cohort that we have in this country.
But we run the risk of people going over the counter to have a purchase and use.
Oh, certainly, and I don't hope and pray. I do hope and pray that no celebrity like we had, in the past with respect to the group will come and endorse it and encourage people to buy it. Dexa is a cheap drug. It's persuasive to see this. There's no need, to rush for it. You get it anytime when it's appropriate, prescribed by a healthcare practitioner. And at this stage, I will implore all the pharmacy outlets and chemical shops not to be dishing out dexamethasone and other steroid medication without prescription, and because they will have to serve as a gatekeeper in protecting the public in this regard. Otherwise, it may lead to untoward consequences that we may have to add on to already bad situation that we find ourselves now.
Now, as we begin to round up our conversation, Dr. Michael Owusu, you now recording 30 to 40% positives out of each 100 tests that you undertake also means that because you want to be sure, the testing time delays. Is that my lay understanding?
I mean, for us, the KCCR, we, since our last backlog, we've put in a lot of mechanisms to ensure that we deliver results at least within 24 hours to 48 hours. So we are not experiencing that. But as I told you, over the couple of this week, we are beginning to have huge numbers, and we are still with strategies to be able to cope up with the numbers. But it is possible that as the numbers increase, if we don't take we may go back to the earlier cases. I mean, the point about PCR technology is that when we started, the prevalence was very low. So you could batch samples and run them. This is why Noguchi could run about 30,000 samples within about 2 or 3 days, because you can put 100 samples together as 10 and run them and get results. But if you have about 30 to 40% prevalence, you cannot batch samples again. You have to run them individually. And this is what makes things very difficult. So when you get to this stage, your testing capacity will naturally fall. You will not be saying that you now have 3,000 testing capacity. It will reduce to about 1,500 and go to about 1,000. It's a natural thing that happens with this. So this is why we are cautioning. The public don't seem to get it. And Dr. York mentioned that we have to involve the public, the media, the chiefs, the opposition. All of them will have to come around the table and then help all over the government to plan and re-strategize. It looks like the conversation is more diffuse, where everybody takes it at every angle, and then everybody wants to carry his own thing. But the reality on the ground and what we are seeing, if we don't involve all stakeholders and sit around the table as one people in Ghana and re-strategize and re-look at the way forward, we may find ourselves in a difficulty, and we don't want to see what happened elsewhere. We knew Africa would be good. Africa will not experience any of these. But then if the pattern is changing and if the data is driving us to this point, there is a need for us to reconsider these things and to look at it. And the media as well. I mean, the media used to give a lot of information in the early stages, educating on staying home when you don't have anything doing, putting on your mask. But as we go by gradually, it looks like everybody is carrying their own story. And the fear and the passion to adhere to precautions. This thing is gradually, the standards are going down, and we are not acting. The security, like Dr. York mentioned, they are not so passionate like before when we are in a lockdown. Now they may see you and you may pass and have your own way. But this is the point where we need them most, because we are climbing this curve. We need them more than ever. So I think we use your media space to continue to appeal to the public, everybody, civil society groups, to the opposition parties and governments and all intellectuals and all well-meaning Ghanaians, religious groups, that let us all sit around the table, let us weigh the evidence that we have on the ground, and let us begin to relook at our strategies and then help the whole Ghana so we can reduce our deaths and then save lives of many vulnerables in the society.
Dr. York, how many of your kind are around Ghana? I mean, the medical doctors. And if you have numbers on nurses, we'll be happy.
Overall, we are about 5,000. 5,000. But those in active clinical practice are just around 3,000. 3,000. 3,000 means that we have one doctor to about 300,000 people. 3,000. No, it's about 10,000, really. Because the population, if you're using the population of 30 million.
Yeah, definitely, 10,000.
Yeah, that's about 10,000, yeah. So it tells you that it isn't great. It isn't great. And so if you are going to lose some of your staff or doctors to isolation and, deaths, then we are in for trouble. Remember that the other conditions are still around. Remember the situation we had in the Upper West where people were dying of meningitis. It's because of COVID. We took our eyes off the ball. We thought that everything else is gone. No, they are still around us. And indeed, those other ones are also increasing because they are receiving less attention as we divert attention to COVID.
And many of you practice in Accra too. That's where the disease is. Accra and Kumasi.
Yeah, like Roland is in Accra, sitting on JoyNews. Most Ghanaians prefer to be in the cities, and even if you encourage them to go, they won't go. And because of the disproportionate distribution of largely social amenities, poor road infrastructure, poor housing, poor telephony, poor water, so that is part of the reason. And over the years, Ghana Medical Association has called for, change in policy to change this narrative. Where over 80% of doctors are concentrated in Accra and Kumasi, metropolitan areas. We call for incentives. Elsewhere, that is what is done. Because if I sit in Accra and I'll get the same money as you sit in Tridium, and when I live in Accra, I can have the opportunity to do extra work in terms of locums. So when I sit in Accra, I will have access to digital television and the best things that are around. And I prefer to stay in Accra. And so to bridge that maldistribution is to provide incentive for people to move out. And it happens. I can tell you, during the Boko conflict, the doctors that worked in the Boko hospital that was run by one of the missions, doctors still were present because of the extra things they were receiving. Compare that to those who were in the other public hospitals, everybody left. So it is shown over the world that incentives help to address this maldistribution. It is practiced in Europe, it's practiced in America, it's practiced in Russia. It is no rocket science, but somebody has listened, but somebody hasn't acted yet.
Yeah. Dr. Michael Owusu, we in Italy and in the UK, we have close to over 100 doctors being infected, and then ultimately it rounded up to 10,000 either recovered or going through and then the fatalities went high. If we have the way the cases are being recorded continuing, what happens to the health system scientifically?
Like I said, Roland, the nature of this virus is that it knocks off your health workers, grounds your health system, whilst infecting and killing people. If you have a full functional health system and the capacity, you can manage these cases and even reduce or, if possible, avoid deaths. This is why the WHO sets criteria for easing restrictions. The second point is that you must have sufficient public health system capacities in place to be able to identify, isolate, test, and treat all cases. They make this clear in their second bullet. So anytime you are in the easing process, you must ensure that your health system is well in place and have all the systems and everything to manage. If the very few people who can manage us are becoming infected and you have to go under quarantine for 14 days, others will have to be treated and manage themselves, then you can see the picture out there will not look very good. And as he said, we are in the rainy season. Very soon, malaria and other pneumonia, respiratory infections caused by bacteria and pneumonia may come in. Meningitis may be setting in. Many cholera may also come with its own problem. Cancer, HIV, tuberculosis, many other things happen within the rainy season. So if there is any drastic action to take, I think that this is the time to do that. And like I said, the health workers, are primarily very, very important. If we don't protect them and give them a breathing space for them to reorganize themselves and then support the health system, then we will run this problem where we will empty the health facilities. The buildings will be there, but the people who are needed to help and take care of us will not be there. And we don't have to get to this point. We still have some period, some flexibility to deal with this as early as possible, so we don't risk getting to the point where we'll have them becoming infected and even dying. And they're also human beings. I said earlier that some of the health workers have chronic diseases. Some of them are hypertensive themselves. Others are diabetic. Others are asthmatic. And they are risking their lives with their own comorbidities to save patients. And if I see my colleague is infected and unfortunately has died, there will be fear. Psychologically, the strength and the energy to even work on patients, even come to work, it will be a problem. So you need to channel resources to this health sector, look at them closely and put in all energy to help support them. Else, I don't know how things will become if we don't do something about this. Things may not be what we expect to see.
Dr. York, what should we look forward to? What are your expectations? What should we look forward to?
I think we've said them. With the increasing numbers, with increasing deaths that we are seeing, and the easing of restrictions, it gives room for concern. Like I said before, we need to change gears and engage meaningfully. And engaging means that every group of persons that matter in this equation of controlling COVID is important. The academicians or the academics, the scientists, the anthropologists, the epidemiologists, the politicians themselves on both sides, the traditional rulers, and for me, they are important. The municipal authorities, they are key in enforcing local, the measures that we put in place, which are being not followed, And I think we should rededicate a lot more resources to make sure that we provide enough PPEs for frontline workers or health workers in general. I don't think there's a need to categorize them. Health workers in general, so that one, they feel psychologically safe even before they approach a patient. And I've seen patients suffer sometimes because the doctors or the healthcare professional feel inadequately protected. So let's look at these things and refocus and re-energize, provide a lot more resources, intensify public education, and let's see whether that is at all possible to look at hotspots and impose local restrictions.
How do we reduce concerns and apprehension of the society, Dr. Owusu? Dr. Owusu? Dr. Owusu? Okay, we seem to have lost Dr. Owusu.
Yeah, can you come again? I didn't get your question.
How do we reduce public anxiety and concern on the psychological parts of because of the incremental number of cases?
Yes, Roland, I think that the public must get to know the truth, what is happening on the ground, so that they can support the government and all the other ministries to implement their measures. It looks like there is a gap between what the public feels and what the initiative the government or the public health division want to take. Because the public feels there is no problem. They feel that everything is fine. They think that we can go about our normal duties. But then those of us on the ground feel that no, the way things are going, based on the evidence we are seeing, the picture doesn't look good. So in order for us to make advances, we need to bring them on board. They have to think like we are thinking. They also have to understand and see the full picture of what is likely to happen if things are not done properly. I'm sure when we get a buy-in from the public, they can support the initiatives of government and then at least help the government to implement these measures we are recommending. So I think that knowing the truth that yes, the virus will run its natural course. You can't stop the virus. The cumulative numbers will go up. But then when your transmission rate is increasing at such a faster rate and it's having pressure on the healthcare system, it's not good news. This is not good news for us. And therefore, the need for us to change strategy is very, very is needed at this critical stage. And they must not feel anxious. They shouldn't feel anxious. They should know that we are telling them the fact, and this is the truth. And they must support government to be able to take bold decisions that will protect their very lives, including myself, protect all of us, and then we can reduce deaths that will happen in the course of the coming weeks.
Well, thank you. I wish you all the best, especially the colleagues of Dr. York who are in the wards and doing the normal clinical work. And of course, those are the lab too. They also face the same risk. Nobody is immune, so to speak. Dr. Ernest York is chair, the Ghana Medical Association for Greater Accra. And thank you for joining me. Dr. Michael Owusu is with the testing center and the research center called the KCCR, based in Kumasi. And the two of you, exemplary, have exhibited good citizenship, and we're hoping that the content that we've provided this morning will serve a great guide. So far, I get it that Dr. Michael Owusu is advocating a localized lockdown in the specific areas where the cases are increasing, even though Dr. Eneziok says, well, it should be one of the consideration, not necessarily, because he knows the implications on whether government would want it or not. But the question is, we're in dire straits. Thank you, the two of you. However, we've pitched this, and what you've taken out of it, it also means that we all have to be cautious. We're in dire straits, according to what the experts say, based on their observation. Give us more feedback, and you can do that through Facebook, JoyNews on TV, and through our Twitter handle at JoyNews on TV, and the comment section on JoyNews TV, as well as myjoyonline.com, where we have a YouTube channel and aggregator platform as our website. In the meantime, let me run this by you. For the show that you've always been in troubled times, for the love and affection that you've always portrayed, for the stern yet essential admonishment you gave when we faltered, for pointing us in the right direction when we strayed, we say thank you, Dad. Pamper your dad with our special Father's Day package and enjoy a 1-month free subscription on the Graphic News Plus app. And the rate for this event is a cool 250 Ghana cedis. And the partners are Lisa Hotel, Silver Star, and ATL, proudly also brought to you by the Mirror, Ghana's most popular weekend newspaper. And Graphic Courier is also on board. So fast, so easy. We hope that you patronize this event and have a time of your life within this COVID times. As we move on, we need to discuss the MPP primaries. We have 168 vacant parliamentary candidacy seats or positions. We have a number of incumbents. We want to speak to a number of these contestants from the Western region, particularly Mama Viosawaji will do that next. Do stay with us.